Hello, welcome to our virtual AHSS project presentation. This project was done with help from the Department of Radiology at the Ohio State University College of Medicine. I'm John Heiniger. I'll begin our presentation and later you'll hear from Keem Palmyra. Our project title is Improving Radiology Resident MRI Safety Education. This project, like many quality improvement initiatives, began by observing and identifying a problem. Both radiology faculty as well as residents anecdotally discussed a lack of competency and confidence in MRI safety principles within both resident education and within the clinical setting, particularly when collaborating with MRI technicians after a safety concern was identified. This was shown objectively by baseline data derived from 5-point Likert surveys assessing a variety of MR safety topics and confidence, which showed baseline moderate but improvable MR safety understanding and execution among residents here at OSU. Where was this problem? This problem was reported most frequently as lapses in understanding when safety concerns would come up from the MR safety officers or the rad techs, and they would ask questions of the residents, and there would be lack of confidence in addressing those concerns. While the most part they were able to answer them, there were definitely times when they felt like this could be improved. This baseline data can be seen at time point 0 in July on our run chart, and I'll discuss that more later. Why is this a problem? It's a problem because practicing radiologists must have a robust understanding and application of MR safety. Gaps in this area can lead to workflow inefficiencies, inappropriate decision and diagnostic imaging decision making, and of course rarely, but perhaps most importantly, it can directly harm the patient. How do we know this is a problem? Well, there's limited resident-specific guidelines, but the ACR and the ACGME standards do expect radiology trainees to eventually confidently, safely, and effectively manage MRI safety considerations in accordance with their training level. So our aim was, by the end of the 2025-6 calendar year, OSU radiology residents will demonstrate and identify improved competency and confidence in MR safety principles and clinical applications, as reflected by higher scores on survey assessments and increased self-reported confidence relative to baseline. We were aiming for scores greater than 80%, 4 out of 5 on the Likert scale. What is the current state? We spoke to radiology faculty, trainees, MR safety officers, and patients to get a kind of better picture of what the current state was. Among physicians, which is this green bar graph, we saw that improved resident education, comfort with medical device safety considerations, and comfort with MR safety risk-benefit analyses, as well as ease of communication between physicians and support staff, were rated highest in importance. Our interviews with trainees also elucidated a number of potential contributors, including but not limited to overly complex initial training, a physics-heavy instruction that takes time to absorb, lack of intentional follow-up with instruction, issues with transparency when questions do arise, if they get elevated to the faculty level, not circling back on how they were handled, and a lack of longitudinal reinforcement during training. We'll touch again on these during our root cause analysis discussion. The voice of the customer patient data showed that while diagnostic accuracy was a major concern, safety of the exams was also paramount. The VOC data from rad techs, which is shown center left, the red bar graphs, plotted a percent occurrence rate for safety events or other issues that arose, not necessarily safety events. But this highlighted their key role in identifying safety concerns, issues with inadequate device interrogation, and that roughly 75% of issues that came up, the residents did adequately handle the safety concerns. The bottom left shows a process map of how we looked into and learned how an MRI is ordered and eventually followed up on and taken for clinicians. We identified the key decision point in this matrix that our project was going to focus on and how our solutions could hopefully integrate with this model and improve it. Keem will now discuss our root cause analysis to identify how best to address this problem.
Root cause analysis. Using fishbone and 5 whys analyses, we identified 5 root causes. Root cause number 1, lack of foundational MRI safety education. Factors include no tiered PGY-based curriculum, no longitudinal reinforcement, heterogeneous training backgrounds, and unstructured decision-making as a result. This was foundational, and it influenced all other root causes. Root cause number 2, no standardized cognitive tools. There are no algorithms or checklists, no structured clearance frameworks, and this leads to uncertainty. Root cause number 3, clinical hierarchy and communication gaps. Technologists often defer to residents, and residents feel pressure to know more than they do. This fear reduces confidence within the residents. Root cause number 4, fragmented screening. Safety issues are often discovered late, and high-pressure decisions are made at the scanner. Root cause number 5, limited point-of-care resources. Residents often have difficulty interrogating devices, and there's no real-time structured support to help them out in this.
Following our root cause analysis, a number of solutions were proposed. We classified their feasibility to effectiveness in order to better appraise their value. A robust medical school MR safety curriculum for incoming trainees was identified as an example of a low-impact, high-effort solution would require informal instruction, revision, implementation into already limited medical school curriculum. In addition, the details of the MR safety education, which are really the most important, would probably be lost for many because of the infrequency of clinical applications, as well as a lack of longitudinal reinforcement. Other ideas, such as offline modules, may be easy to deploy, but are not often as effective. Conversely, MR safety simulations, huddles during clinical routines, and safety resource references were high impact, but not pragmatic for our year-long project from students without a robust understanding of the clinical workflow and insufficient training and experience to design these reference texts. Working with our advisors to refine the already deployed trainings and implementing a new case-based curriculum to emphasize real-world applications, offer an educational space to ask questions, and design purposeful longitudinal follow-up emerged as an intervention with higher feasibility and higher impact, which we ultimately pursued. The training modules present at baseline were deployed now with a case-based curriculum created by us, the medical students, faculty advisors, as well as the MR quality specialists. It was piloted and refined with faculty advisors before implementation from June through August. And as we deployed it, we tracked the resident performance over time with those surveys I discussed earlier, and we observed an increase in their mean scores, suggesting improved confidence and competency with these MR safety principles.
Health literacy and barriers to equity. Although our intervention targeted radiology residents, a highly medically literate group, we wanted to consider scalability and equity. Currently, materials are delivered in English, training assumes high technological literacy, and content is tailored to radiology trainees. If expanded, adaptations would include plain language versions, multilingual materials, non-digital alternatives, and inclusion of other clinical staff. We also recognize that MRI screening involves patient communication. Future iterations could incorporate teach-back methods, simplified screening language, and visual aids. While health literacy was not central to this internal training intervention, ensuring scalability without increasing inequity remains important for sustainability. Results. Knowledge improved significantly after modules. Confidence in real-world application improved significantly after case discussions, and residents reported improved comfort collaborating with technologists. This supports a blended educational approach. Modules help to build knowledge, while case discussions build structured thinking and confidence. Control plan and sustainability. We outlined several ways to sustain these improvements. Process standardization through modules being integrated into Buckeye Learn, adding these modules to resident orientation, and storing these modules on the Radiology QI SharePoint for access whenever a resident requires them. Another way is documentation, such as having an MRI safety education policy on hand, reusable case packets, just-in-time MRI safety algorithm posters, and summary outcome reports. We also suggest reminder systems, such as auto-renewal module notifications, visual reference posters, and annual orientation reinforcement. Transfer of ownership of this project would be to Dr. Anthony Salvador, Dr. Zareen Shah, and Brett Bryan. Future directions include expanding the case library, integrating nursing education, and broadening interdisciplinary implementation of this program. Conclusion. In summary, we identified measurable gaps in MRI safety competency among radiology residents. Through structured modules and longitudinal case-based discussions, we achieved significant improvements in knowledge, confidence, and clinical application. MRI safety is improved through structured decision-making, communication, and systems awareness. Strengthening education at the trainee level improves safety upstream. Thank you.